Since the advent of cardiac surgery 60 years ago, intraoperative myocardial protection or cardioplegia respectively has been an essential part of open heart procedures. Experimental and clinical research on this particular field is still continuing because an optimal or ideal cardioplegic solution has not been established. In the past, surgeons focused, among other criteria, on intra-ischemic myocardial energy turnover or morphology, while today safety and convenience are the main parameters for evaluation of any cardioplegic method. Regarding surgeons' convenience, it is obvious that cardioplegic reperfusions or administration of maintenance solutions are the most inconvenient and time-consuming procedures. The following remarks focus on a method to avoid such cardioplegic reperfusions without compromising patients' safety. The answer to this progress is called Custodiol. Since the advent of cardiac surgery 60 years ago, intraoperative myocardial protection or cardioplegia respectively has been an essential part of open heart procedures. Experimental and clinical research on this particular field is still continuing because an optimal or ideal cardioplegic solution has not been established. In the past, surgeons focused, among other criteria, on intra-ischemic myocardial energy turnover or morphology, while today safety and convenience are the main parameters for evaluation of any cardioplegic method. Regarding surgeons' convenience, it is obvious that cardioplegic reperfusions or administration of maintenance solutions are the most inconvenient and time-consuming procedures. The following remarks focus on a method to avoid such cardioplegic reperfusions without compromising patients' safety. The answer to this progress is called Custodiol.
Custodiol is a low-sodium and low-calcium cardioplegic solution and the only highly buffered compound available worldwide. Significantly, the histidine buffer represents the primary osmotic ingredient of the solution. In addition to its buffering capacity, histidine is one of the most effective scavengers of free radicals known, with its mode of action comparable to mannitol. Due to its highly concentrated buffering capacity, this solution requires only a singular administration to initiate cardioplegic arrest. What are the indications to use Custodiol? At first, pediatric cardiac surgery. Also valvular surgery, followed by aortic surgery, minimally invasive surgery, redo surgery, heart transplantation. Finally, it can also be used in coronary artery surgery. In accordance with Dr. Cooley's recommendation, administration should be safe and simple, routinely using a 3/16 perfusion line and the 9 French aortic cannula. For intraoperative cardioplegia and transplantation, antegrade cardioplegic perfusion is preferred with necessarily a high-volume perfusion. Furthermore, in this situation, the extended perfusion time must be considered as the total extracellular myocardial space requires adequate equilibration. Custodiol can be used at any patient age. However, in pediatric cases, special considerations apply. The perfusion volume must be adjusted for the infant's age, and perfusion time is shorter than in adults. Cardioplegic reperfusions appear to be harmful in neonates, as the listed references clearly demonstrate. How do we administer custodiol? After aortic cross-clamp, it is first necessary to empty the aortic root and the left ventricle. Then the cardioplegic perfusion is started. The solution can be administered either by roller pumps or by gravity. Electrically induced ventricular fibrillation should be avoided before cardioplegic perfusion starts, since the coordinated ventricular contractions during the initial phase of cardioplegic perfusion result in optimal equilibration. The decrease in the arteriocoronary venous PO2 difference is not affected by the mode of perfusion. The crucial reduction in the decline of the difference of arterial coronary venous oxygen partial pressure reflects reduced myocardial energy consumption, which, in turn, correlates with a corresponding increase in myocardial cell energy content. The solution's temperature should be kept between 6 and 10 degrees centigrade. Any unused portion from the initial perfusion should not be stored in a refrigerator, as rewarming will decrease the solution's pH, adding to the acidotic shift in ischemic myocardium. As already mentioned, cardioplegic reperfusions are not usually necessary. If, for some reason, cardioplegic reperfusion is necessary, perfusion time should be limited to 1 to 2 minutes, equivalent to 200 to 400 ml. Time lapse is the primary drawback of any replegia. It is evident that replegia is well known to be harmful to the neonatal heart. In case of initial retrograde administration and of retrograde replegia, consider the physiological fact that only 70% of the coronary venous blood drains into the coronary sinus. Consequently, right heart failure constitutes the main risk of retrograde administration. One additional concern relates to blood pH after systemic custodiol administration. The pH of this buffer-containing solution is temperature dependent. At 34 degrees centigrade, the solution's pH is 6.9. We can predict the blood pH following systemic custodiol administration and thereby calculate the pH shift towards acidosis that is solely attributable to physicochemical effects. How to manage custodiol perfusion in patients with severe aortic insufficiency? Try to perfuse antegradely first. If the heart does not stop within 3 minutes, open the aortic root and continue with isolated left coronary perfusion. In most cases, the heart will stop with this approach. If it does not, interrupt the left-sided perfusion and perfuse only the right coronary artery for 1 to 2 minutes, and then continue the left-sided perfusion. If retrograde perfusion is preferred, perfusion pressure should be only 20 to 30 millimeters of mercury. Systemic administration leads to hemodilution, which can be prevented by a hemofilter. It has been suggested that systemic custodial administration leads to neurological seizures in neonates due to systemic hyponatremia. However, this is not the case. Studies from Norway and Italy demonstrated that an apparent hyponatremia based solely on measured laboratory serum concentrations is not causally related to seizure activity in this situation because it is isotonic. To prevent such hyponatremia, administration of 200 to 300 millimole sodium to the body's circulation is recommended. Obviously, sodium chloride must not be added directly to the cardioplegic solution because this would seriously interfere with its effectiveness. Our recent retrospective as well as prospective studies on systemic sodium content and osmolality clearly support the validity of our aforementioned protocol.
Welcome in Module 3.4, Minimally Invasive Surgery, Right Lateral Thoracotomy Approach. Listing of available resources: Professor Obadiah's Instrument Platform brochure, Professor Obadiah's Instrument Platform surgical video, Obadiah Atrial Retractor SPD in-service video, instruction for use of the Obadiah Atrial Retractor. If we have a look to the Delacroix-Chevalier matrix, this module is going to introduce our solution for mitral surgery via a right anterior thoracotomy approach. This is the Obadiah instrument platform. We are consequently located in the box mitral, minimally invasive of the matrix. Here is a slide to introduce the Obadiah platform. It is designed to perform mitral valve surgery using a right anterior mini thoracotomy. The skin incision size is approximately 5 cm. The surgeon works video assisted or direct vision and using a peripheral cannulation technique. You can see on the top right a picture of the mitral exposure using the 3D Obadiah atrial retractor, and then on the bottom left the retractor and a single shaft V-handle robust needle holder. The main operative benefits of this technique are: you have an improved exposure thanks to the use of an endoscope, there is no sternum division, it allows a shorter hospital stay and provides better aesthetic outcomes. In this module 3.4, we are going to introduce our Obadiah instrument platform. We've called it Obadiah 2 as this is the second generation of this set. Here is the front page of the brochure where you can see 3 boxes showing the 3D atrial retractor, the intercostal retractor, and minimally invasive scissors handle, recognizable thanks to their blue and gray handles. Let's start with a presentation of Professor Jean-François Obadiah. He is a French surgeon based in Lyon University, the second largest hospital in France, and one of the most famous heart centers. Today he performs about 150 cases per year, and most of them are mitral valve repair. He also regularly organizes postgraduate workshops for international physicians. Lots of different approaches can be used to perform mitral valve surgery, from full sternotomy to microthoracotomy using the robot. His surgical approach is circled in green. He performs his main incision, approximately 5 cm in size, in the right side of the chest between two ribs, which can be slightly spreaded. 2 additional ports are used, one for the endoscope and one for the aortic clamp. What are the main benefits of minimally invasive approaches when we deal with mitral surgery? First of all, we access the heart between the ribs and spare the sternum. Trauma is reduced, and this permits a short skin incision, even if it's not the first goal. There are several other advantages. A reusable transthoracic aortic sheathwood clamp can be used. The mitral valve is really well exposed for 2 main reasons. First, the access to the valve is more logical because you remember it is not horizontal when we access it from the sternum, but in this case we select the correct intercostal space in order to have the mitral valve in a horizontal plane. And secondly, we can magnify the valve thanks to the endoscope. We can then use the same repair procedures using classic techniques, and patients are now more and more requesting for minimally invasive techniques. For the patient, there is a better aesthetic result. It's less painful, there is less risk of infection, less trauma, the hospital stay is shorter, and there is no patient re-education. Unfortunately, right lateral thoracotomy approach has also some disadvantages. It may require the use of an endoscope. There is a learning curve because cannulation techniques change, video assistance has to be understood. It is not applicable to all procedures. The most complex cases will have to be dealt using a sternotomy, and bypass time is slightly longer. Minimally invasive techniques gain market shares compared to 10 years ago. Around 60% of isolated mitral valve repair are performed using right lateral thoracotomy in France, 2015, and it was about 50% in advanced hospitals and countries. This is another example coming from Germany data in 2013 to demonstrate that there are less and less isolated MVR sternotomy, and in the same time more and more isolated MVR thoracotomy. We can also see that mortality is lower when we perform MIS MVR compared to the one we have in sternotomy. Have a look to this slide presenting each group of surgeons depending on the approach used to perform isolated mitral valve repair. To this point, the ultimate step in minimally invasive valve surgery is complete video assistance leading to the smallest and least invasive incisions. There are key paradigm shifts that occur in the process. There are also key areas for which we want to help bridge the surgeons into assuming the role. After this short introduction, let's now introduce the instrument we promote to be able to work efficiently using a right lateral thoracotomy approach. This set has been designed by Delacroix Chevalier in association with Professor Jean-François Obadia to perform video-assisted minimally invasive mitral valve surgery. The first step is to perform the intercostal incision and retract subcutaneous tissues and ribs. A specific retractor is designed to retract both soft tissues and ribs using the same blades. This is the C-ring retractor. We decided to look at a few design enhancements compared to the previous version. First, you immediately see the elliptical shape, hence the name C-ring, thereby optimizing the space where the atrial retractor will be placed. Then there is a rigid platform which supports the spring, where we can place the sutures during the prosthesis implantation step. So this device is not only an intercostal retractor, it also replaces the disposable blue and white suture organizer. Here is a picture of the same C-ring retractor, but with the blades that we are going to present in the following slide. Those blades are reposable, meaning that they can be cleaned and sterilized to reuse them, but with a limited cycles. They are manufactured with a rigid stainless steel frame, and then they are silicone overmolded. The rigid frame will apply tension on the ribs to slightly retract them, while the soft silicone retracts soft tissues. Consequently, they are cost-effective because this retractor is a 3-in-1 design, a retractor, a soft tissue, and a suture organizer. They are in addition really easy to use. Place first the blades into the chest cavity and then connect them to the retractor frame. Here are two pictures showing the retractor with and without a soft tissue retractor. Notice there is no immediate difference in soft tissue retraction. You can also see in the right side of your screen the importance of having removed a part of the spring frame to become a C-ring shape. It leaves space for atrial retractor insertion and placement. Other kind of blades are available if your customer prefers to work with full stainless steel blades. The attachment stays unchanged, but there is no silicone overmolded on them. Our main competitor for this device is Miami Instruments in the USA, which promotes a full disposable device directly mounted on an intercostal retractor. It seems beautiful, but it is probably bulky because higher than our integrated system, as the ring is assembled on the retractor frame. A single shaft suture catcher is important to catch pericardium sutures directly through the chest. Pericardium sutures are used to position and expose the heart. This one is reusable and has an exclusive small blunt distal tip to easily catch sutures. An important step prior to each cardiac valve repair is the aortic clamping. An aortic clamp is used to stop the heart beating while the extracorporeal circulation machine takes the lead and replaces the heart and lungs. Here is the endoscopic view of the jaws, which are progressively clamping the ascending aorta. The transthoracic aortic clamp used is part of the VATS product line. It is a long instrument with rings and ratchet in the proximal part and sliding shaft to reach the DeBakey jaws. It is specifically designed for long cavities and small incisions, and there is only one mobile jaw to avoid pulmonary artery damage. It is reusable and is inserted in the 5th intercostal space. The proximal part can also slightly retract the lung to participate in the exposure quality. Several sizes and models are available in the VATS range, references DC8099. Until now, we have performed the intercostal retraction, heart has been exposed and arrested. The next step is to perform the left atriotomy and the left atrial wall retraction in order to reach the mitral valve. This exposure will be possible using our 3D Obadia atrial retractor. The atrial retractor has different components, but the most important ones are the tube and the blade. The blade is directly inserted through the main incision, but the 5 mm tube requires an additional hole in the chest, close to the sternum. Then the tube has to be connected to the blade. Here are some pictures showing the Delacroix Chevalier solution to this exposure issue. The following slides are going to present the main features and surgical benefits. Please refer to the movie SPD in-service video available in the resource area to have more information about the components, assembly and disassembly, and reprocessing. The first operative benefit is that it's the only atrial retractor in the market which is autostatic. It doesn't require a surgical arm mounted on the operating table to be stable. It remains stable by itself because the blue tripod assembly tightens the whole system against the chest cavity. Thanks to this technical feature, every part of the system remains in the sterile field. The blue tripod system is designed with 3 pieces: the base, the ball, and the crown, allows a 3D orientation and 1 translation to adjust the depths. 4 degrees of freedom are available to accurately position the retractor and obtain a nice valve exposure. Once the blade has been inserted through the main incision and the additional puncture has been done to insert the tube, we have to connect those 2 pieces together. A special J-groove fixation has been designed in the tube to secure the tube and the blade together, even if there is lateral effort applied on the blade. Using a standard screwing solution, a lateral effort could unscrew the blade and consequently become less stable. Using this J-shape groove, no residual movement is possible once the blade is in place. The atrial retractor system is provided with 3 atrial blades. The width is 35 mm, but the depth changes from 30 to 50 mm. In option, 3 additional larger blades are available: 40 by 50 mm, 40 by 60 mm, 40 by 70 mm. Once everything is assembled and the atrial blade is in place, use the Luer lock to retract the atrium wall until you have a nice exposure of the mitral valve. At this stage, screw the crown to secure the position. Then, an additional feature will increase the exposure. Using the blue hood of the rod, screw until the blade begins to tilt and then choose the correct angle to have the best exposure. The blade can tilt from -10 degrees to +30 degrees. It will improve the visualization while stretching out the mitral valve. Let's now introduce the additional lateral blue flex blade. It is a soft blade, reposable, which can be used if the lateral atrium wall in the right side of the atrial blade hides the mitral valve. Our retractor is above and beyond the competitive scope based on the self-retained concept, and most importantly, being the pivoting atrial blade allowing angle retraction from -10 degrees to +30 degrees. Even with the additional benefits of our atrial retractor, what can be a common issue in atrial retraction? Visual obstruction due to the lateral atrial part has to be fixed. The blue flex blade should be atraumatic, easy to use, and rapid to deploy, but it has to be compatible with the small skin incision performed. So we need to place it straight first during its insertion into the chest cavity, and then bend it to position it in the right side of the atrial blade. 2 specific forceps are used to apply both the stainless steel blade and the blue flex blade. Once again, refer to the in-service video to see the insertion step by step. Here is a picture once the atrial blade is in place, and you can see we have a good retraction of the atrium roof, but we cannot visualize properly the mitral valve because the atrial wall is obstructing our vision on the right side of the atrial blade. Here is another picture with an additional flexible blade which retracts the right side. the exposure of the mitral valve is much better. Another one where we can see both the atrial blade and the flexible blade. The exposure is perfect, we can easily recognize the mitral leaflets and the chordae. To recap, this additional blue flex blade retracts the interior face of the left atrium and the part of the septum. Key features recap of the complete atrial retractor. It allows an enhanced exposure of the mitral thanks to the adaptable orientation, the tilting blade, and the additional lateral flexible blade. It is a secured platform because it is really stable thanks to the J groove, and every part remains in the sterile field. In the minimally invasive surgery catalog, you will find the Obadiah atrial retractor information. DC81115-00 is the main reference, and then you have to choose the applying forceps, the optional rigid blades, and the blue flex blade. Please note all the system is fully reusable except the blue flex blade, which is reposable. A specific sterilization tray has been designed to store all the spare parts during cleaning, sterilization, and transport steps. The next slides are going to present our main competitors regarding atrial retraction. First one is Geister with an atrial retractor which required to be mounted on a surgical arm. It is delivered with 6 blade size options and a forceps. It is an easier system, but it doesn't provide any vertical lift nor lateral retraction. USB Medical from the USA offers a solution which also requires to be mounted on a surgical arm. The rod has to be screwed down the blade, and a lateral retraction is possible using the hinged blade. This is probably our stronger competitor because the device is easy to use and efficient. Esculap also promotes a solution with a lateral retraction. This is possible using a malleable blade located inside the atrial blade. If needed, you have to grasp the additional blade using a forceps and bend it to have the retraction you need. We can think that bend the blade should not be easy deep in the chest. Once we've achieved a perfect exposure, we can begin to work on the mitral valve. V-handle single-shafted instruments will be used to work accurately deep in the chest. Reminder about V-handle single-shaft instruments. Proximal part contains a handle and a luer lock. The handle is made with our supergrip polymer and the shape allows a good handling. Use the luer lock at the end of the procedure to clean the inside of the tube. Please refer to the movie in the research area of Module 3.3 for more information about single-shaft instruments reprocessing. Then there is a long 5 mm diameter shaft to get a 36 cm long instrument and the jaws which are accurately milled. Differentiation is one of the most critical factors in successfully marketing our products. It enables another point of engagement. It is a presentation of source, quality, benefits, and reason. Remember the color differentiation designed using the handles. Blue and blue for forceps, blue and white for needle holders, blue and gray for scissors. It will facilitate the job of both nurses and surgeons. First instrument is a Risano forceps, called the magic forceps if we refer to Professor Alain Carpentier, who used to perform the entire procedure using this forceps. It is specifically designed for minimally invasive surgery, valve surgery, to grasp atraumatically the leaflets and papillary muscles. Really useful also in case of calcified tissues. Then we promote the same forceps but with Debaki jaws instead of Risano jaws. This one is also age-dramatic and exists in two versions, a wide forceps 2.75 mm and a narrow forceps 1.5 mm. They are mainly used for prehension during the dissection steps. For valve surgery, they can also be used to grasp needles. Concerning scissors, we do need strong scissors to be able to cut calcified tissues. That's why you find here our robust MIS scissors with the 7 mm diameter head. This will provide an improved cutting power. Two curvatures are available, a curved model and a strongly curved model, depending on the size of the annulus. Let's now talk about the instruments used during the suturing steps. I mean, when we insert sutures in the native annulus and pass sutures in the prosthesis mitral ring or valve. Valve surgery means big needles, between 5-0 until 2-0. We need a robust needle holder to strongly hold the needle between the jaws. This instrument will improve needle stability, and this is really appreciated by surgeons. There are two models, one straight and one curved. Last but not least, they are designed with the EasyLock system to never lose the needle in the patient chest. A word about our competitors when we talk about minimally invasive single shaft instruments. Geister has a range without any differentiation between their models, and they have less models than Delacroix Chevalier. They have an interesting feature. It is possible to adjust the jaws opening in the open position, but we receive really few demands, so we think surgeons always prefer to have the maximum opening offered by the instrument. Failing main differentiation is the black coating you will find on all their MIS instruments. We understand that it provides less light reflection and more resistance to corrosion, but it is not often requested. The range is limited in models and lengths. Aesculap provides a color differentiation on their handle like Delacroix Chevalier, with blue handles for scissors, black handles for needle holders, and green handles for forceps. The range is limited to the essential basic instrument. Finally, the last main competitor is Wechsler, located in Texas, USA. There is no differentiation in the jaws because no important key opinion leaders, and the range is limited. So why Delacroix Chevalier for single shaft instruments? Because we provide differentiation thanks to the super grip handles, which are more comfortable, the patented EasyLock system, the robust scissors and needle holders with bigger heads, or the reposable scissors tips for sutures while using a reusable handle. Also because we had new models every year. Once the sutures are in place, we have to make knots and tie them. A knot pusher is used to reach the area where the knot is going to be tightened. We specifically designed this knot pusher with a high-grade polymer tip for perfect sliding and gliding. That tip is perfectly polished for suture tearing prevention. The knot cannot escape from the instrument, and the design of the tip allows to push the knot until the very last millimeter, even in very confined area. The instrument is fully reusable and can be provided in two different fixed lengths or in an adjustable version. The disadvantage is that it requires assistance help. All our main MIS competitors have designed an equivalent. Geister, Felling, and Hestec have a full metallic knot pusher, and we know the sliding capability is reduced compared to the medical grade polymer we use. you can see that their models look like the one initially designed and launched by Delacroix Chevalier. Wechsler also has a fully metallic nut pusher but with a funny handle, while Miami Instruments has designed a fully disposable product just to push and tie nuts. A magnetic retriever has been designed in case a needle is lost in the chest, as it could be not easy to catch it deep in the chest using a regular forceps or needle holders. This instrument is magnetic and will easily catch the suture. Obviously, the magnetic power is not too high to avoid damaging any tissues. Atraumatic hooks are needed during mitral valve repair, mainly to try chordae to see if they are working well or if they need to be replaced by a Gore-Tex. They can also be used to manipulate the leaflets or help to tie knots. Several tips are available, please refer to the catalog. They are all available with fixed and adjustable lengths. Everything is reusable with round tip to be atraumatic. This one is a 2-in-1 hook instrument. The handle can slide along the bar depending on the tip you want to use. There is one small hook for cords and vessels and another hook, larger, for nerves. For instance, if we follow the picture, if we want to use the small hook located on the right side, unscrew a little bit the handle, move it to the left, and screw to secure the handle placement. Then the instrument is ready to be used. Again, a word about our competitors regarding accessories. As usual, Geister has a good reputation and works with well-known key opinion leaders like Professor Moore to develop their instruments. Fehling still uses the black coating on all their instruments. While Aesculap and Wechsler have designed similar hooks but without any differentiation. Our differentiations: super grip handles, adjustable length options, and several models. When one or several chordae have to be replaced, we need to accurately measure the correct length we need. A specific instrument has been designed in association with Professor Obadia. The distal tip is made of 2 small hooks you can move using the handle. Enter the instrument until you reach the subvalvular anatomy. Slightly unscrew the grille piece at the end of the handle and then move the sliding part of the handle to adjust the length between the 2 hooks. Once you've selected the correct length, screw the grille piece in order to secure the sizing. You can then remove the instrument from the patient's chest and reuse this length to prepare your neocord. 2 models are available, one straight and one curved, which is more adapted to the anatomy. The rod comes apart for a more efficient cleaning. Both Geister and Fehling have a regular metal basic design for the chordae ruler, without curved version and integrated locking mechanism. Consequently, you have to be cautious when removing the device because the length could be modified if you hit something. Here are some additional MIS instruments used during the procedure. A reusable single shaft scalpel blade holder is needed to perform the procedure. It can be used for skin incision, pericardium opening, and also sometimes to help decalcify the annulus. It is compatible with 6 blades models which are disposable, and you still find the blue ergonomic handle. A suction tube is also very important to keep the field dry. This one is designed specifically for MIS approaches as the length is suitable for right lateral thoracotomy. The tip has small holes to suck liquids and it can be removed in order to suck solid debris. Finally, there is also the super grip ergonomic handle on this suction tube. We've seen earlier the MIS debulking forceps. This one is the very same instrument but with curved jaws. Really useful during dissection as it is easier to see the distal tip. We have also developed the MIS handle, reusable, on which we can use a reposable scissors tip to cut coarse tissues and sutures. The main advantage is that you always have the same cutting quality thanks to the blades, because the tip is reposable, and once the blades begin to cut less efficiently, you have just to replace them. It is another differentiation we have in the MIS product line compared to competition. Those scissors are specifically designed to cut coarse tissues and sutures using a strong ring handle design. They have specific curvatures to easily reach mitral annulus. MIS tube passer are always needed at the end of the procedure for thoracic drain tubes setting. 4 models are available, 2 lengths and with or without ratchet. The jaws are specifically designed to firmly grasp thoracic drain tubes. As usual, specific sterilization trays are requested to store all the instruments of this set. Here are the 3 recommended trays to store all the instruments. They protect your instruments during transport, cleaning, and sterilization. Professor Obadiah 2 instrument platform is a full set of instruments which allow you to perform mitral valve surgery via a right anterior thoracotomy access. You will find in the brochure or at the end of the MIS catalog the recommended platform with all the important information. To conclude, Obadiah's instrument platform optimizes access thanks to the intercostal and atrial retractors, increase exposure thanks to both retractors and instruments, and facilitate precision. Surgeons more and more request to learn this technique even if there is a learning curve, because they know that it's important for them and for the hospital to stay attractive. Regarding the atrial retractor, it provides a superior retraction of the left atrium, not only the roof, but also laterally, and consequently it increases the exposure of the mitral valve. The instruments are low profile but robust to work on the mitral valve, and all the set is specifically designed to improve surgical outcomes. Thank you very much for your attention.
Bismillah ar-Rahman ar-Rahim. Good afternoon, ladies and gentlemen. Today is the second day of SCTS Ismailia Masterclass. I am very proud of the first day. We have enjoyed it very much. I have so many feedbacks from both senior and junior cardiothoracic surgeons. All are appreciating the talks and enjoyed it very much. They are all thanking the speakers for their effort. It was really perfect. I was worried before that the whole meeting is taking place on a digital platform online, but I found it is very useful and valuable. Really was amazing. It is the first time for me to attend the whole sessions of one conference in my life. I was there all the time. Today we have lectures in adult cardiac surgery and transplantation. I will leave now my friends Seri and Nareen to introduce the faculty. Thanks.
Thank you, Mohammed, for a lovely introduction. And I shared Professor Amer's sentiments. We were concerned whether we will be able to pull off this meeting in a virtual platform with the faculty all placed in United Kingdom to an audience in Egypt. And the tech company and the software has proved exceptionally great. And we had a fantastic day yesterday, having a whole array of thoracic topics and pediatric cardiac surgery. Today, we move on to the second day, where we have engaging faculty from cardiac surgery to take you through the whole spectrum, and then pediatric cardiac surgery. My only request to the delegates is you will not get this exceptional faculty talking to you personally. Please make use of this opportunity by asking them any questions, however trivial or complex, in the chat box, so that they can all be addressed at the end of the sessions. Professor Ahmes also promised that the whole session is recorded, so hopefully it'll all be placed in the YouTube or CTS net for those who missed out. Over to you, Naren.
Shri, thank you very much for the introduction, and also just to echo yours and Mohammed's comments about yesterday. It was a real privilege to see the program and how the collaboration between the two societies has brought on such an educational event. And as you said, it works seamlessly with the technology that we have available to us. So I hope it's being enjoyed by the delegates and the audience, both actually in Egypt and in the United Kingdom. So we hope to continue that today. As mentioned, today we'll be focusing mainly on adult cardiac surgery, as well as the evening session will be on cardiothoracic transplantation. So as Shri said, we welcome your interaction as much as is possible in a virtual event. And today, what we're going to try and do is collate some of the adult cardiac surgery questions to run at 6 o'clock after the two sessions have gone on. Would I be able to share my screen, and then I can share the program with the delegates, if that's okay? Just wanted to first introduce our esteemed faculty. We are really honored to have some great presenters today, and they'll give you some of the insights into cardiac surgery and cardiothoracic transplantation. And also later in the afternoon, we'll be having some operative videos to give you some tips and tricks on how surgery is performed. The first faculty I'd like to introduce is Mohammed Osman, who's one of our senior clinical fellows at Papworth. And actually, it's his enthusiasm personally thank him for his, as I said, enthusiasm and passion to make all of this happen, initially on the live events, but now even with the virtual events. So, and we welcome him as part of our faculty today. We have two esteemed colleagues from London, Kulvinder Lal, who's one of the senior cardiac surgeons at Bart Heart Centre, and we'll be talking to you today about aortic valve disease, and Prakash Punjabi, who's a professor at Imperial College, and will be giving us some insights into mitral and tricuspid valve disease. And then finally, we've got Arvind Singh, one of the senior consultants at Basildon Essex Heart Centre in Basildon, and we'll be talking to us about thoracic aortic disease. Following on from that, in the presentations in the early afternoon session, we've got Simon Kendall, who's our president of the Society for Cardiothoracic Surgery in Great Britain and Ireland, and he'll be giving us some insights into how the specialty has dealt with the challenges of COVID over the past years. And I think we've all valued the opportunity to learn from each other about how to deal with this, with the pandemic that has affected us all in many different ways. So Simon will give us some insights into that. As I said, the late afternoon session will be having some operative videos, tips and tricks. And then in the afternoon, we'll be moving on to cardiothoracic transplantation. And that will be mainly delivered by one of my colleagues, the senior transplant surgeon at Royal Papworth Hospital here in Cambridge, David Jenkins. Will be giving you lots of insights into how transplantation and mechanical support is performed. And then finally, we'll have Mininder Kalkut, who you had the pleasure of listening to yesterday, will give us some insights into thoracic and lung transplantation. As I said, we're going to try and run today by having some question and answer sessions broken into the day. So at the end of the adult cardiac surgery session, somewhere around 6 o'clock, we will try and run the question and answer session for adult cardiac surgery, and then the faculty can disappear after that. And then similarly, we'll run a question and answer session regarding transplantation at the end of the three talks in the evening. It's a long day, but I hope that we're able to enthuse and give you lots of insights into the practice that we run here in cardiac surgery. And as I said, please make it as interactive as possible within the confines of the technology. And please send us some questions. And we hope you enjoy the rest of today. So thank you. Thank you. So to start off today's adult cardiac surgery program, I'm going to be giving you a brief presentation on cardiac anatomy. This will start with some of the basics, but hopefully will give you the foundations of some of the clinical presentations that we will have later on coronary disease and valve disease and thoracic aortic disease. Apologies for some of the more senior members of the audience today. Some of the aspects I'll be covering will be relatively basic, but as I said, hopefully will give you the building blocks of the presentations that will be continued later today. I'm hoping to give you an overview of the mediastinal structures, where the heart sits within the mediastinum, the cardiac structures themselves,